Welcome to the ThinkData Podcast in partnership with Dataworks. Today's episode, I'm joined by Caroline. She is the CEO and co-founder of a really interesting business called 𝐬𝐮𝐬𝐫𝐢𝐻. Caroline is an ex-clinician turned healthcare exec. The ultimate aim of the business is to reduce readmissions and improve patient outcomes. For the listeners here in the US, obviously the healthcare system is universally broken. And actually what Caroline's objective here is to really bring her unique perspective as a previous patient herself, but now as a provider, on real how that kind of innovation and compassion piece can really reshape the whole of health, which is super interesting. And I'm glad you came on because I know obviously reached out to you specifically and through the work that we do in healthcare. I've obviously come across 𝐬𝐻𝐬, come across you before, but do you mind for the listeners kind of bringing us up to speed where the idea for 𝐬𝐻𝐬 came about? Because I know it's quite unique and quite personal to you.
Yeah, so thank you for having me.
Pleasure.
It's actually a real combination of a few things. So my background is I'm a PA, a physician assistant, and clinical leader, and I worked in emergency medicine for longer than I'm going to say on this podcast. And I always saw patients coming back through this because the ER is the front door to the hospital, and people come in through there and they had just been discharged, and it was silly things like, oh, they took the wrong medicine when they got home, or they had a question they couldn't get answered and they felt like they had nowhere else to go. And there's all of these reasons that people kept coming back, and it was always so like disheartening to see. And I also, I worked that way as a clinician, and then I had my own health journey. So I've had breast cancer twice
Wow.
in my 30s, and actually after my second breast cancer treatment was over, I had a surgery on my chest and experienced a readmission myself. And it was, I know the health system, I know what I'm supposed to do, but I think denial is a strong thing,
Mm.
and also when you're the patient, it's a different experience. And so I actually had an infection after that I realized late and had to get admitted for IV antibiotics. It was actually super traumatic to my daughter who had been through so much with me already, but I had managed to stay home the whole time, and I think something about me going into the hospital just was incredibly traumatic for her,
Mm.
and I I was like, "This was silly." Like, there has to be a better way to reach everyone and everyone where they're at, because we all have different circumstances in our lives and barriers to success, and I really just wanted to find a way to do that better. I also had been working in another startup where we were operationalizing some work, and I was creating these programs where we were doing very little for people after they went home, and I was seeing really, really incredible, profound outcomes. And I was like, this could change healthcare, and
Mm.
this is just doing the right thing for people and giving them a hand to hold along the journey. So, I guess. Uh, I look at it like continuity of care is the issue, not necessarily the quality of the care people
Mm.
receive. Like, I think there's brilliant clinicians all over the country taking care of patients, but there's a gap for people when they go home. I describe it like in the hospital, you get 100% of everything done for you. Like, when do you go to the bathroom? When do you take your medicine? When do you take a walk down the hallway? What do you eat? When do you eat? Everything is decided for you, and you literally have a button in your hand that if you have a question, you just press it and you get instant help. But as soon as you leave the four walls of the institution, it goes from 100 to 0. People are that the dynamic of that time has changed a lot, like, length of stay in hospitals is getting shorter, so people are going home in a more acute state. Their
Mm.
health status is in a greater flux, and they have resources that are wonderful resources like caseworkers, social work, nursing, visiting nurse that help piece together this time for patients, but there's no overriding clinical decision making to make sure that physician to physician contact is never lost for the patient, and that whenever they ever have a question or they reach out their hand for help, that there's always a hand reaching back out towards the patient to grab them.
Yeah, I love that. I think it's I said this offline to your agency that's working with you, and said actually when you've got a passion and a personal experience that is driving the messaging and the business, ultimately that business, it means a huge amount, but equally it's going to lead you to make better decisions where it's actually, yes, obviously the bottom line is important, but equally you want to do right by the patients, you want to do right by your community, which I think's and I've never heard of that solution. So what I'm really interested to touch on, how does it work in practice? So how does, I think what's very clear is the reason it's been set up and the problem you're solving, but how does it work in practice? And obviously I know I mentioned at the top of the call, kind of artificial intelligence is kind of the buzzword at the moment, but talking
Yeah.
about the technology as well, how does that look?
Okay. Well, there's a lot to that question.
Okay.
So I'll dig in. Practically for the patients, I explain it like this. The doctor that takes care of you in the hospital has one hand. It's time for you to go home. We grab the other hand. We hold on to your hands until we can give you back to your care team, so your primary care doctor or the specialist, so that you're never without that clinical care. So a patient on their from their perspective will have a initiating visit with us as soon as they go home, usually within 48 hours. We have found that, and there's a lot of research that actually supports this, that if you can intervene with the patient within the first 72 hours and grab a hold of them, then you can drastically change their outcomes versus waiting any longer than 72 hours. And on average in our country, people have the average time to follow up with a primary care doctor or specialist is over a month. So
Wow.
it's pretty drastic. Yeah. So that's a big gap that
Yeah.
exists right now. And so for the patients, we hold on to them till we can hand them off. Our interaction with them is a series of virtual visits, phone calls, text messages, surveys, texting. So they always have like this high communication. And on the back end, our medical practice is supported by the software that we're building, which recognizes risk and will create optimized care plans for patients and like the formula for what they need based on all of the factors that feed into this
Mm.
algorithm. And we can dial up or dial down for the patient as they progress through their healing journey, assessing real time dynamically how they're progressing. So we have the medical practice backed by our software and the AI that we use. We actually use it in some boring ways, like for automations and for pulling data in and out of things. And
Mm.
I think the more interesting thing that we're building now with our data is our ability to be predictive and proactive. So we're using data to inform care and help recognize who needs what and who's at risk for what before anything happens, so that we can set up the right safety, what do they call them, the bowling alleys, those like
The
bumpers,
guardrails. Yeah.
before anything bad happens.
It's really interesting. I think because obviously within the US, you'll have a centralized kind of your medical records, your EHR. So obviously that's where your kind of medical records are kept. And obviously, are you therefore directly accessing that data to ensure that those personalization of kind of post care and is really relevant to the specific needs of that? Because obviously that's sometimes the risk, isn't it? You're going based on what they're putting into your system as opposed to actually what they need.
Yeah, so well, like, slight correction there, like, there's a million different EHRs, there's definitely not one oh, maybe I missed what you said, but, yeah, data sharing is a big barrier
Mm.
to great care. I think
Yeah.
that's, like, you're spot on with that, and, we've tried to overcome that in a few ways, because not only is it that data is difficult to get, and then you can get it, which we can, but then you have to like, it's not in readable format, and if
Hmm.
clinician's trying to take care of someone, it's not in front of them in a way that they can, it takes 15, 20 minutes to read through a chart for someone that's minimally complicated.
Mm.
So we actually do. We pull from various sources the patient's records and information so that we can have it all optimized for that patient. We use that data also to help decide who needs what. And it's a mix of like their past medical history, medications that they take, personal capabilities, their social determinants, all of those things go into
Mm.
making, and then also our clinicians' perspective on what their interaction was with that patient and what they might need. So all of that feeds into the predictive analytics that we do, and then we take care of the patient based off of that.
Yeah, I think it's so accurate in the sense that there's all this data to kind of access, but actually accessing it is sometimes the barrier, and that's ultimately in care that has kind of huge potential ramifications for the patient. So from a compliance, governance, privacy standpoint, you've obviously got an AI component within your product, which AI to a lot of people is great. It's solving a lot of problems, but within healthcare, there's still obviously that reluctance or nervousness around putting some of the decision making in the hands of an AI. So how are you kind of ensuring that everything you're pulling out, is obviously compliant, governed the right way? On your point, the guardrails are in place to ensure that when you're speaking to your patients and they're kind of the customers, that they're comfortable with that what you have is completely monitored and is ready to be used.
So I think that's a great question. And I mean, I think the potential for AI in healthcare and decision making and really most basic stuff that's needed in healthcare, like that to me is, I think what we see in healthcare today and what we're going to see in 5 years is going to be drastically different. And I don't know, my team might be like, this is the worst analogy ever, but I think of it like I'm a very pictorial thinker. And I think of like a bull that's going to go into a bullfight. They have got like multiple gates that have to get lifted before the bull actually gets out into the ring. And I kind of look at AI as AI informed care as that bull. And these fences or guardrails are
Mm,
in place, and they can slowly be removed as the technology evolves and becomes safer and more reliable and less biased. And the way we use it now is everything in the front is a human being for that patient. So our first visit with the patient is a half hour long and minimally. And that's not including the preparation and the decision making that occurs afterwards. And so we spend a lot of time connecting with the person because I think trust is like the most fundamental component of healthcare compliance.
100%.
I want that with our patients. I'm like, if we don't know their dog's name and like, who they live with and like their spouse isn't on the phone or on the call or video with us, like we didn't do a good enough job. Like we
Mm,
know this person. And I think the technology has to get to that level before that's patient facing. And also it's not legal for AI to make decisions in the US on clinical. AI can't be a doctor.
no.
But we do use the analytics from it to inform the care, and I can give you some examples if you want.
Yeah, great. Please do.
I think we have some that are, like, wildly obvious, and it's like, why aren't we just doing this anyway? And I think one of those is we take care of interventional radiology patients that receive a port for their chemotherapy, and we know that for those patients, the readmission risk for a, uh 42-year-old single person is the same as an 80-year-old married person. Now, there
Okay.
is some correlation causation that we haven't teased out yet, but this fix to this to me is like, there's so many things we could do to just mitigate that gap so
Mm,
quickly. And that's a wild number.
that is a wild number.
Yeah, and so for, also we know, like, which days the highest rate of readmission occurs on and for what percentage of patients, and we can tease that through to do better interventions. We've had a lot of great success with, like, post-ortho care and minimizing, complications after an orthopedic surgery also this way. We noticed a pattern of pain with people receiving laparoscopic surgeries and
Okay.
worked with our physician referring, surgeons, and a whole slew of them actually decreased the amount of pressure that's in the belly, that's insufflated into the belly at the time, and all of these patients and their complaints with their pain went away. It went from everybody complaining to all of the patients that had less insufflation, none of them complaining. So,
Wow.
really, like,
That's just using the
beautiful.
data, then you're obviously
It's
being
the data.
really, yeah, it's fascinating. And I think you're right. I think we're a long way away from kind of AI being your kind of your GP, your doctor, your physician. But I think where we've seen is on your examples, the great examples you gave there, the ability to look at data quickly, succinctly, and make suggestions. Equally, workflow automation in customer, patient engagement. So I think that's where you're really in that niche. And I'm really interested to talk. I know you went right back at the beginning. Obviously, there's a personal driver here. There's a personal experience behind Dimer that led you to think, hang on a minute, I could really help fill that void. But ultimately, it is a business, and you are growing something, an entity. So I'm really keen to touch on the steps you took to build the business. So, the ideas, they're great. This is kind of the niche, this is the focus. But how did you get going? What was that strategy around building product market fit, those, the research, the interviews, the kind of the initial conversations? Talk to me about that.
So I think I picked, my co-founders too. I'm not alone here. I have two co-founders. And they're brilliant, way smarter than me. I think one of them is also a PA from the ER, and this was an obvious problem. This was an obvious answer. And then I validated it in some of the work that I did before. And he actually did a doctorate in using technology to reduce ED revisits. And we both were like, we already know this is going to work. We already knew it. Was just convincing the world. And I think selling into healthcare and building in healthcare as a small little startup is like an exercise.
Yeah.
I actually told my co-founder 𝐬𝐮, I was like, I've never been rejected this much in my life as I have since I started hanging out with you.
It means you're onto something, I guess.
Yeah. But I know that I just know it because I've done it. I've seen it. I've lived it. I've experienced it. All of these, I just know that this is what we need to do. We started this with very grassroots, and we knew the technology. We had this idea of the technology we needed to build. We also know what sort of the secret sauce is to capturing patient trust and having them convert to actual the Dimer Health experience. But and I also had watched before other startups really struggle because they needed to generate revenue, and it took a long time. It takes a long time in healthcare to do that. So that's why we started our medical practice. And I was like, let's carry the torch of our product. Not only will it inform the product, but we'll also be able to bill for services at the same time and make some money and demonstrate our outcomes, which we've been doing for about 1.5 years now. And we've done exactly that. So
amazing.
We've sort of did a bottom-up, top-down approach. And as we were gathering all of this data and outcomes and success with our initial partners that were referring patients to us, the bigger health systems and payers and entities that we were targeting started noticing because we're disrupting a current
Not so many
way.
rejections now. Yeah.
Yeah. No, I mean, we still get them sometimes, but we're just going to wait for them to come back later and say, okay, now we're ready.
Yeah.
And
awesome.
yeah. Yeah, I think the biggest barrier is that large institutions think they're already doing this, and trying to explain that we're not competition. We're here to amplify what we're doing. Yeah, and everything you're doing is amazing, and not only are you going to keep getting good results, we're going to take the benchmarks of success and totally destroy them and make them way better. So that's my goal. Because I think there are benchmarks and goals that entities are accountable to, but I don't think they're good enough.
No.
So,
it's amazing you say that as well, because having that kind of such high level of expectation on both sides from the way you're holding your business to account, but also the health system providers, is ultimately going to lead to better patient care and better outcomes anyway. And I think it's just a win-win for everyone involved, isn't it? And actually, it also means that you're freeing up those medical centers or wherever they've come out of to focus on what they need to, the people that are in hospital, as opposed to having to worry about people who have left their care.
Yeah, and if you think about it, no patient that just that, say we work with surgeons, they get interrupted all of the time during surgeries, during their office hours, to deal with anything going on with the patients that they previously took care of. And one, you don't want to be that person on the OR table when there's a big issue happening with another patient that interrupts your surgery. And
Yeah.
two, um, like it's unnecessary. Like the people go home and I mean, we're doing hip replacements same day. People go home same day. That's a very traumatic event to your body. Like even if it's a good thing, it's still a traumatic event. And to go home like that, sure, medicine wears off after a couple days. You start feeling the pain. It's not getting better as fast as you think it should. Like it's people need some hand holding more than what they have, and also the ability to recognize what needs to come back to the hospital and what doesn't. And right now, I think it's over $60 billion of unnecessary cost to the health system because we're not doing this well now.
Yeah, which I think is you go back to your earlier point about the rejection when you've got those stats and those figures and the actual on your point of year of doing this now or having those wins, you can actually reference those data points and actually it makes it a little bit easier when it comes to having those harder conversations. And if you had your time again and you looked at kind of the last few years and I know obviously you've had evident challenges to overcome as any business, but what would you do differently, if anything? Is there anything you think there's that one moment in time you think, do you know what? I really wish we'd done something differently. Or do you think everything's just a learning point anyway?
I mean, I am incredibly hard on myself and
Yeah.
on like I think we all really hold the team up to high expectations.
Mm,
I think more so like here's the thing, like, I like, going back to the beginning of the conversation, what became abundantly clear to me as I was going through my last treatment, and the last time I was sick, like, it was late, like, we didn't know if I was gonna get better,
mm,
and so I was very fortunate to have an amazing team take care of me, and I had a very unpleasant, long treatment window, and
mm.
so by the end, I was really beat up, I couldn't even get up off my couch,
Wow.
and I would just sit there, and the things that became priority to me were very clear, and, like, beyond the people that I love and wanting more time with them and with my daughter, but it was also this, like it's like I said, "Go big or go home," like, we live once, our time is short, we're just humans here on this earth, and, like, if I have something in me or an idea, like, I just feel like I owe it to myself to try so hard that even if we fail, at least we tried,
Yeah.
and, so I look at it that way, like, I think it is all a learning experience, I think looking back, there are some things I was naive to that now I'm not. Uh
Battle hardened.
A little bit. I try not to get too hardened, but I will say it's been the most inspiring journey, like, meeting other people in innovation. I've met some amazing VC leaders that really understand how their their investments can change, like, the whole system and
Mm,
want that, and also healthcare leaders. Like, really, I've been so inspired by so many people that I don't know that I would have had the chance to meet had I, like, played it safe for myself.
yeah. I love that. No, it's a great answer. I think there's so much passion coming through and inventiveness coming through, which is great. And I think for you, as much as you can say, but what are your plans though for the business and the product over the kind of coming 6, 12, 18 months? I'm assuming you've got some form of roadmap, but what can people listening in here, what can they expect to see from you guys?
We just are gonna continue to grow. I think this is an exciting time for transitional care, so that's, like, our big focus. I think some areas where I see huge opportunities I think change is always really painful and really hard, but it's also an opportunity, and I think what's happening in Medicaid, right now, we can totally change how we take care of people, and especially in populations with access, deficits and that where budgets are getting cut, we can really significantly save those budgets a ton of money.
Mm,
Hopefully that saves programs and jobs so that, and people get more care. And so I think to me, that's like an opportunity that to meet all of our values and goals and do good for the health system and also continue to expand as a successful business. To me, that's like an obvious area. And then, yeah, just expanding in multiple states. So we're heading into Texas soon, hopefully
wow.
California after that. So yeah.
Just the small ones.
Which is the hardest one. We're doing the hardest ones first.
I was going to say, get those out of the way. Caroline, honestly, it's been one of the most heartfelt and authentic interviews I've ever done on this. And I think just in terms of what the problem you're solving, your background, I'm sure people listening to this will really resonate. If people are interested just to explore what Dyma do on your website, I'm assuming, is there some case studies, things they can look at, things they can, obviously we'll tag you in this one when we go live anyway, but what can people see on your website if they take a look?
Yeah, so there's a lot about the company. There's a video about the patient experience. There's links to different articles in our blogs that, the leaders in our organization have written. So it's www.dymarhealth.com. And and Google us and see what patients have to say. I think to me, that's the most beautiful thing is, the feedback from the people we take care of and that allow us to be part of their healing journey are the best. Like, that keeps me going on hard days.
Exactly. And on that, I think it's a great way to kind of end the conversation. I really appreciate it, Caroline. It's been, really enjoyed it. And I'm looking forward to this going live. I'm sure it'll be a very popular episode when we go live. So thanks again. It's been my pleasure.
Thank you, Alex.